So this slide on coronary plaques. This is a cross section of a coronary artery. So you're looking down the coronary artery. So on the left side, it's a stable plaque. The cap is completely surrounding that cholesterol and lipoproteins that are within the plaque. So the blood in the coronary artery is not seeing what's beneath the cap. It's stable. And on the right is a unstable plaque that's ruptured, and it's now going to cause the blood to coagulate onto it and occlude the coronary artery, leading to acute coronary syndrome, which you know now is one of three things: unstable angina, which you haven't had a heart attack, so your troponins will be negative. But you could have ECG changes of the angina, but the symptoms are much different than a stable angina. You could have an NSTEMI, which is an infarct, but not a full thickness infarct. And you could have a STEMI, which is a full thickness infarct. Both of those, NSTEMI and STEMI, release troponin into the bloodstream. So let's do a case here just to try and put some of this together. So a 63-year-old man presents to the emergency room with chest pressure, neck pain, left arm pain. Symptoms started 2 hours ago and is associated with sweating and weakness. His risk factors for any kind of coronary artery disease, atherosclerosis, is that he's a smoker, he's overweight, and he has high cholesterol. His father died of a heart attack at the age of 55. His brother died at 50 with some kind of heart issue. His past medical history is that he has chest pain with exertion/activity for the past 2 years and uses nitrosublingual. So that's telling you that he has stable angina in the past. But now it's completely changed, which has prompted him to present to the emergency room. So what's happening in the coronary artery? What do we think is going on? And of course, this patient's going to need an ECG and a blood test to distinguish what's happening. So something's completely changed in terms of the symptoms. He has chest pressure without exertion, neck pain, arm pain. He's sweaty, weak. So we're very suspicious these are cardiac symptoms. So, and in the setting of him having stable angina, meaning a stable plaque in one of his coronary arteries, this is very suspicious for a plaque rupture. So a complicated plaque that's ruptured and occluded the coronary artery, leading to one of three things in the umbrella called acute coronary syndrome. So this could be unstable angina, where we will likely see some changes on the ECG, but the blood test for troponin will be negative. This could be an NSTEMI, where we'll see some changes on the ECG very often, but no ST elevation, and the blood will be positive for troponin. This could be a STEMI, where we will see ST elevation on the ECG, plus a positive troponin in the bloodstream. So we can really separate it into different categories based on the ECG and cardiac enzyme testing called troponin. So this slide's just writing down the thinking pattern of how this case has progressed to someone with stable angina, to someone who has developed acute coronary syndrome, where the plaque has ruptured, and now we're left with something much more urgent, such as unstable angina, NSTEMI, or STEMI. And we can distinguish those by ECG and blood testing. Now, acute coronary syndrome means when you present to the emergency room, if we suspect you have acute coronary syndrome, you're not going home. You need to stay in hospital. That plaque is ruptured, and you're at risk of progressing to a full blockage if it's not already blocked in the coronary artery. So what do we do? Well, as I said before, we do an ECG, IV, O2, and a monitor. This is always for any cardiac symptoms. So you can just say it very quickly. ECG, IV, O2, monitor for almost anything that's critical. So if you don't know what to say to someone when you're doing one of your simulators and it's a cardiac or respiratory, ECG, IV, O2, monitor. Because you're going to do all those things to monitor a patient and to diagnose them. So how do we treat this? Well, it depends on what the ECG and the blood work shows. So if it shows unstable angina, so a negative troponin, but some changes on the ECG, that we'll go into some changes later on, and a negative troponin in the blood, so no troponin, so there hasn't been a heart attack, we'll sometimes treat this with, well, we will treat this with aspirin, antiplatelets such as clopidogrel, and sometimes anticoagulants. But we don't give thrombolytics unless it's a STEMI. Okay, thrombolytics are only for a STEMI. Sometimes we'll use beta blockers and calcium channel blockers to slow down the heart, because these are negative inotropes and negative chronotropes. So they slow down the heart and they reduce contractility. So they both reduce the workload of the heart. So you can see a whole bunch of different blood thinners, aspirin, clopidogrel, which we can use to try and thin the blood to keep the blood flowing through the coronary artery, and then beta blockers and calcium channel blockers to rest the heart. In a STEMI, we want to open up that vessel now. So we have two choices: a thrombolytic, like TPA, or an urgent cath referral, a cardiac cath, where they can do an angiogram, which is a dye test, to look at the coronary arteries. So you get transferred to a cath lab. You get injected with a dye that can look at the coronary arteries, and then they can see where the blockage is. And at the same time, with the device that goes up the artery, either from your wrist or your groin, they can open up the artery by going through the blockage, and with angioplasty, they balloon it open, and then they put a stent across it to keep it open. So that's for a STEMI, where we give urgent thrombolytics or the cath lab to do angioplasty and a stent. Okay, so sorry, I just saw it below. So the medical treatments. So when we say medical, we mean usually medication, like non-surgical options, and then the surgical options become the angiogram, which is the dye test, the angioplasty, which is the expanding balloon across the blockage, and then the stenting, which is the metal stent that goes and keeps the artery open where it was blocked. If when they do the angiogram there's blockages everywhere, then sometimes you need a coronary artery bypass surgery. So that's where they take, it's open heart surgery, where they take the arteries and they bypass them with vessels, with arteries or veins from other parts of your body, often your legs. They harvest veins from your legs, and they do bypass surgery on your heart. So this slide about coronary artery blockage / occlusion symptoms. So what are the symptoms that someone will present with if one of their coronary arteries has become occluded, or say they have a plaque rupture and suddenly the vessel is either 99% occluded or 100% occluded. There's very little flow going down the coronary artery. So chest pressure and chest pain and pressure, people describe this in all kinds of ways. They call it heaviness, tightness, like a band across the chest. It can radiate up to the neck or the jaw. You can get upper arm discomfort, left or right. You can sometimes have nausea and vomiting with this. You can look extremely pale and very sweaty, and that's because the sympathetic system has been turned on, because it's detecting a cardiac event. So, and it definitely doesn't want your blood pressure to drop. So it's been activated from the pain, and also it's sensing that something is happening with the heart. You can have shortness of breath as a symptom of angina or a heart attack or unstable angina. And you can have weakness. Old people present often with just weakness. They have no pain, they've just been weak for the whole day, and they just can't get up, and it ends up being a heart attack. So the symptoms and how they behave kind of lead you to think of what it is. So if it's exertional chest pain that resolves with rest and nitro, well, that's stable angina. If it's unpredictable chest pain with rest pain, completely unpredictable compared to activity, it's a chest tightness. We do an ECG, we might see a couple of odd looking changes on the ECG and the troponin is negative. Well, that's unstable angina. If it's chest pain with sweating, pale, sudden onset, radiates to the neck, I'm just giving you an example here. The troponin is positive in the blood. The ECG shows some changes that we sometimes see with an N-STEMI, but there's no ST elevation. Okay, we call it an N-STEMI, a non-ST elevation MI. And then, of course, a STEMI would have all those symptoms. The troponin will be positive in the blood, and the ECG will show ST elevation. Okay, so I won't go through the A, B, C, D here because I've done that before. And the slide on the right, or the image on the right, is again just showing you the progression of what a plaque does. What's the concept of collateral vessels? So if you have atherosclerosis that is gradually blocking up coronary arteries that are feeding your heart, if there's enough time, the body can make little tiny arteries that go around the blockage, and they're called collateral vessels. They bypass the blockage. So this is with gradual process of atherosclerosis and increasing plaque size within the arteries. Not something that happens suddenly out of the blue in 2 days. This is a gradual process to make collateral vessels. Okay, so as the original coronary arteries become blocked, there's been time to make new small vessels that can bypass it and feed the heart. So they can be very useful if the initial artery completely blocks. You can minimize your damage by having some collateral flow of blood. Okay, and that's the concept of collateral arteries, collateral coronary arteries, or collateral arteries anywhere. You could have, if you have a slow progression of atherosclerosis in one of your legs that spans over a year, the body will make collateral arteries, little vessels to bypass the blockage to continue feeding the leg. So this is just another example or another diagram of collateral circulation from an occluded artery, where if there's enough time, new arterioles, new small arteries can bypass the blockage. So how can we diagnose coronary artery disease with some imaging, with different types of tests? So not everybody can have what's the gold standard, an angiogram, where we put a catheter in the artery of your wrist or the catheter in your groin, and we move the catheter all the way up to the into the aorta until it reaches the aortic valve, which is right where the coronary arteries come off, and then we put dye into the coronary arteries to see if they're blocked. And that's the image you're seeing on the right here. So not everyone can have that, and not everyone needs that. So the first one is an ECG. We can see a lot of changes on an ECG that can help us diagnose coronary artery disease, including heart attacks. So ECGs can be very useful, and it's just the 12-lead ECG that the computer puts onto a piece of paper and we read it. The next one is called either a treadmill stress test or an exercise stress test, where we put the electrodes, the leads on you, and we get you to run on an exercise stress test or an exercise treadmill. And as your heart goes faster and faster and faster, we're checking the monitor to see if there's any changes on the monitor that might indicate ischemia from you having a fast heart rate on the exercise treadmill test. Another one is where we inject a chemical into you called thallium, and we get you to exercise, and then we take images of your heart, and the thallium goes to different areas of the heart depending on whether it's ischemic or not. So it's just another way of viewing the heart by exercising it with thallium on board to see if there's areas or there's territories of the heart that aren't being perfused by the coronary arteries. Stress echocardiogram. We'll put you on a treadmill. We'll get you to run very, very fast, lie you down, and do an echocardiogram, which is an ultrasound of the heart, which tells us if there's abnormalities of the valves, if there's abnormalities of the heart pumping, if there's different parts of the myocardium that isn't pumping at all. So a stress echocardiogram will tell us a lot of information about how the heart is pumping, and you can see the chambers of the heart pumping. And when we stress the heart by you running fast, we can bring out abnormalities on a stress echocardiogram. A dobutamine stress test. So you can't get on a treadmill test because you have knee arthritis, you have hip arthritis, you have a disability, something where you just can't get your heart rate up to a fast enough rate for us to have a good idea if there's any ischemia when your heart rate's going, because you need to get to a certain heart rate for these tests. So for some people, we just inject dobutamine that stimulates the heart because that's a beta agonist. And it's going to make the heart go fast, and then we'll have a look with the electrodes that are attached to you. So you never actually get on a stress test. We just inject you instead and make the heart go fast. A cardiac CAD scan. So this is a CAD scan that looks at the coronary arteries. Okay. There's a couple of things to know about what to do prior to having a cardiac CAT scan. Typically avoid caffeine 12 hours prior to, no food or fluid 4 hours prior. With any of these tests, it's a good idea to check with the healthcare practitioner which medications to continue. And of course, wearing good walking shoes, comfortable clothing, because many of them you're going to be exercising. Now, why do we want to see which medications. If you're on beta blockers or calcium channel blockers, that might stop you from getting to a certain heart rate, which is needed on many of these stress tests to see how the heart responds to a fast heart rate. So many of the stress tests, we ask people to hold their beta blockers or calcium channel blockers a few days before the test. Invasive monitoring or testing, sorry. So the invasive testing, an angiogram. So that's where we inject dye into the coronary arteries, and we have a look to see if there's any blockage. If you look at the image on the right, you'll see the horizontal artery that's going from left to right across the heart is blocked midway. So you can see a little bit of blood flow in the middle of it, but the rest is blocked. So this is an angiogram. At the same time, when you do an angiogram, there's also the equipment to do an angioplasty, which goes through the blockage, balloons it open, and then you can put a stent across the vessel to keep it open. So this is definitely the gold standard to see the coronary arteries, but it's invasive. There's a risk to it. You can bleed from the site of the puncture at your wrist or your groin. You can get blood collections there called hematomas. You can get heart arrhythmias because we're sending dye down the coronary arteries. So it's an invasive test compared to the other ones. Okay, so coronary angiography. So as we mentioned before, this is an invasive test. So there's a catheter that's threaded into the radial artery of your wrist or the femoral artery in your groin, and it's feathered all the way up to the initial part of the aorta where the coronary arteries come off, and then dye is put into the right and left coronary arteries to see. And then we take images to see the coronary artery flow, and if there's blockages on the way in the coronary artery. So so on the right here, sorry, on the left, A is a coronary artery. I think that's the right coronary artery that's coming down and then wrapping around the heart. And you can see that in the middle, the flow is very, very small, just trickling through there where the arrows are, from the start of the first arrow to the end of the second arrow. And this is after angioplasty and stent. Look at the flow now. So there's full flow across or through that coronary artery now. So it can be a very, very effective for angioplasty and stent insertion. There is obviously some pain involved in getting the catheter into the wrist or the groin, but after that, it's really a painless procedure. We typically observe people afterwards, after an angiogram, for 4 to 6 hours. And one of the main reasons we observe them is to make sure that they're not bleeding from the arterial puncture they just received, whether it's in their groin or their wrist. The wrist artery is becoming much more popular because it's very easy to compress after the procedure, and it's a much cleaner area than the groin. And the groin is a difficult area. If there was to be a lot of bleeding, it's harder to compress there. The procedural time of a coronary angiogram is typically about 45 minutes to an hour. So here's diagnosing coronary artery disease, cardiac CT. So you do get lovely images on a CT angiogram. So you still need to receive the dye, and then you get multiple slices of a CAD scan, multiple images from a CT scan. The problem is that, okay, yes, there's there's a good chance we can see the occlusions, the blockages in the coronary arteries. The downside is that you can't do anything about it with this test. It's only for diagnosis. And you also have to accept radiation exposure from the CAD scan. It hasn't really taken off as a fantastic test. So this particular test is great for looking at the coronary arteries. We can also do angiograms of other organs, such as the lungs, to see how the flow of blood is through the lungs. We can do angiograms of the brain to see the flow of blood throughout the brain, but it's really just diagnostic, a CT angiogram. So there's nothing you can do even if you see a blockage. Then you'll have to go on and still have the angioplasty and the stent. Okay, so let's do a question here. This one's not super. Okay, next question here. When developing a health teaching plan for a